Welcome to This Explainer. Today we're decoding a crucial roadmap for saving lives, the adult cardiac arrest algorithm. If you've ever looked at one of these advanced life support flowcharts and just felt totally overwhelmed by all the arrows, medications, and decision trees, well, you're in the right place. We're going to break down this life-saving protocol visually so you'll know the exact sequence of actions to take when literally every second counts.
Here's our roadmap for today. First, we start at no pulse. Then, we'll walk through the shockable rhythm pathway, followed by the non-shockable rhythm pathway. After that, we'll look at evaluating rhythm changes, treating reversible causes, and finally, mastering high-quality CPR.
Okay, let's dive into Section 1. Start here, no pulse. This is where cardiac arrest begins.
Right at the very top of the algorithm, you see the words no pulse. That means the patient is in cardiac arrest and has no effective circulation. Now, in real clinical practice, before we even start analyzing this graph or trying to figure out the exact rhythm, action is already happening. The moment cardiac arrest is recognized, we immediately start high-quality CPR, begin bag mask ventilation with oxygen, and get a cardiac monitor or defibrillator attached without delay. We absolutely never delay compressions, but once that monitor is hooked up, the algorithm truly kicks in.
And that brings us to our first major fork in the road. The diagram splits into two distinct rows based on one absolutely vital question. Is the cardiac rhythm shockable or non-shockable? The top row is for shockable rhythms, and the bottom row is for non-shockable ones. Which path we take here dictates literally everything that follows.
Section 2. The shockable rhythm pathway. Basically, using electricity to fix the problem.
So this upper row deals with ventricular fibrillation, or VF, and pulseless ventricular tachycardia, also known as PVT. In VF, the ventricles have this chaotic electrical activity and they just can't produce an effective contraction. In pulseless VT, the ventricles are beating incredibly fast, but they aren't producing enough output to actually create a detectable pulse. The absolute priority here? Early, unsynchronized defibrillation. These are electrical rhythms, so they can potentially be terminated by an electrical shock.
Let's look at how the start of that timeline actually plays out. If that very first rhythm check shows VF, or pulses VT, indicated by that green plus sign, we deliver the first shock. But pay close attention to what happens right after. Immediately following that shock, we resume CPR for 2 full minutes. We don't stop to check the pulse. Even if the shock worked, the heart might not be pumping effectively just yet. During this 2-minute CPR cycle, the team is busy getting intravenous or IV access, and if that's taking too long, intraosseous or IO access is a fantastic backup.
Now, looking at this sequence, you might be wondering, why on earth do we wait to give a powerful drug like epinephrine? We've just shocked the patient, we're doing CPR, but we haven't pushed any meds yet. Well, let's move to the next part of the sequence and see how this builds. In a shockable arrest, rapid defibrillation is always priority number 1. Epinephrine is only brought in after initial attempts at CPR and defibrillation haven't restored circulation. So after 2 minutes of CPR, we check the rhythm again. Still shockable? We deliver shock 2. Now we immediately restart CPR and give 1 milligram of epinephrine. The epinephrine causes vasoconstriction, which increases coronary perfusion pressure to help jumpstart the heart. And we'll keep giving that epinephrine every 3 to 5 minutes. If, after another 2 minutes, they are still shockable, we deliver shock 3. It's at this point, while CPR resumes, that we introduce an antiarrhythmic, like amiodarone at an initial dose of 300 milligrams or lidocaine at 1 to 1.5 milligrams per kilogram. These medications are used to fight those stubborn, shock-refractory rhythms.
When we talk about delivering these shocks, we're using a single shock strategy. We do not use stack shocks without doing CPR in between. For a modern biphasic defibrillator, we typically use the manufacturer's recommended energy, which is often an initial dose between 120 and 200 joules. For older monophasic units, the recommended dose is 360 joules. Actually, fun fact here, biphasic shocks are more effective at lower energy levels because they send the current in 2 directions, which causes less cellular damage to the heart.
All right, Section 3, the non-shockable rhythm pathway. This covers PEA and asystole.
This lower row is for pulseless electrical activity, or PEA, and asystole. PEA means you can actually see electrical activity on the monitor, but the patient has no pulse and no effective mechanical circulation. Asystole? That means flatline, absolutely no meaningful ventricular electrical activity. And this brilliantly illustrates why a defibrillator is completely useless here.
A shock is designed to reset disorganized or rapidly circulating electrical rhythms. With PEA or asystole, there's just nothing for the shock to reset, so we do not shock.
Because we aren't prioritizing a shock, our immediate timeline looks totally different down here. If the rhythm is PEA or asystole, marked by that green minus sign, we immediately continue CPR for 2 minutes. But notice the big contrast. We give 1 milligram of epinephrine as soon as possible. Unlike the shockable pathway, non-shockable arrests require early epinephrine to really try and stimulate that cardiovascular system.
As you scan left to right on the lower row, you'll spot several no-shock symbols. That doesn't mean we're adding weird new treatments. It just clarifies that at every brief 2-minute rhythm check, if they are still in PEA or asystole, we still don't shock. We just keep doing what works. Continuous 2-minute CPR cycles and pushing epinephrine every 3 to 5 minutes, all while trying to figure out what caused the arrest in the first place.
Moving on to Section 4, evaluating rhythm changes during those brief pauses. You'll see those brief pauses marked by the black zigzag lines on the algorithm. At each check, the rhythm might actually change. If it shifts to VF or PVT, we jump right up to the shockable pathway. But if an organized rhythm suddenly shows up on the monitor, we rapidly assess for a pulse. Organized rhythm but no pulse? They're still in PEA. But if there is a pulse, incredible, we have return of spontaneous circulation or ROSC. We stop the arrest pathway right there and instantly shift to post-cardiac arrest care. By the way, an abrupt jump in end-tidal carbon dioxide on the capnography monitor can be a really great early clue for ROSC.
Section 5. Treating reversible causes. This is all about hunting for the why.
Right at the bottom of the diagram, it clearly tells us to treat reversible causes in all rhythms. This is absolutely crucial, especially for PEA, which is almost always caused by an underlying physiological crash. We use memory aids to find the culprit quickly, starting with the 5 H's. We're looking for hypovolemia, which is severe fluid or blood loss, hypoxia, or inadequate oxygen, hydrogen ion excess, meaning severe acidosis, potassium emergencies, like hypokalemia or hyperkalemia, and finally hypothermia, a severely reduced body temperature. Honestly, any single one of these can stop a heart in its tracks.
Next, we hunt for the 5 T's. Tension pneumothorax, that's a collapsed lung putting immense pressure on the heart. Cardiac tamponade, where fluid builds up in the sac around the heart. Toxins, like drug overdoses. Pulmonary thrombosis, which is a massive blood clot in the lungs. And coronary thrombosis, an acute heart attack. The team has to continuously investigate these H's and T's across both the shockable and non-shockable pathways, because if you don't fix the underlying cause, the algorithm just won't save them.
Finally, Section 6. Mastering high-quality CPR. This is truly the foundation of success.
These metrics are literally the most important repeating element in the entire diagram. Medications and shocks will never, ever replace high-quality compressions. Let's be crystal clear on the standards here. You have to compress at a rate of 100 to 120 beats per minute. You need to achieve a depth of at least 5 centimeters or 2 inches. You must allow complete chest recoil so the heart can actually refill with blood. You've got to minimize any pauses in compressions, avoid excessive ventilation, and this is a big one. Change the person doing compressions every 2 minutes so fatigue doesn't start ruining your compression depth.
The way we manage breathing during CPR also evolves. Before an advanced airway is placed, the team uses a strict ratio of 30 compressions followed by 2 breaths. But once an advanced airway is secured, the whole rhythm changes. We move to continuous, uninterrupted chest compressions, delivering just 1 breath every 6 seconds, so that's about 10 breaths per minute. We also use continuous waveform capnography to monitor that airway and ensure our CPR quality is actually moving blood through the body.
Bringing it all together, let's look at our roadmap to resuscitation one last time. It all starts with recognizing no pulse and instantly providing high-quality CPR. We check the rhythm to determine our path. If it's a shockable rhythm, like VF or Pulseless VT, we prioritize early defibrillation, working in those 2-minute CPR cycles and introducing epinephrine after the second shock, with antiarrhythmics coming later. If it's non-shockable, like PEA or asystole, we don't shock at all. We rely on those relentless 2-minute CPR cycles and give epinephrine as soon as possible, all while desperately searching for those reversible H's and T's.
This algorithm isn't just some poster on a hospital wall. It's a synchronized dance of science, teamwork, and stamina designed to pull someone back from the brink. The visual cues, the 2-minute arrows, the shock symbols, the rhythm checks, they're all perfectly designed to keep a clinical team aligned in the absolute heat of the moment.
So here's the question. Now that you understand the logic behind every single arrow and dose, when seconds count, are you ready to lead the algorithm?